People have a misunderstanding what palliative care is. I think when they hear palliative care, many times they think of hospice. Hospice is a great thing that we have to take care of patients at the end of life, especially in that last 6 months. It really is palliative care at the end. However, palliative care can be involved with any patients, many times years, maybe even longer, before they're close to the end of their lives. Really, what palliative care is a specialty made up of multiple different providers, nurses, social workers, physicians, chaplains, addressing patients' holistic needs. So we go beyond just the physical. My part of the job is to help with physical symptoms and to talk about goals of care related to what a patient would want. But I know that I'm not the best person when it comes to emotional issues or when it comes to existential or spiritual issues. And that's why I have a team to really help out and take care of patients at the end of life. The best way to think about palliative care is that we help with the symptoms and stress of a serious illness, and we're there to help take care of you and your family during that time. So if a diagnosis of a serious illness such as metastatic cancer or COPD or heart failure, we can actually get involved and assist with the symptoms related to that and talk to the patients about what they understand that's going on with their symptoms as well as their diagnosis. We talk with the patients about what their treatment options are and what they understand that the physicians are doing for them. Many patients don't seem to know exactly what the doctors are doing. Part of that is the problem with the doctors. We're horrible at communicating in my experience with patients. However, when you sit down and talk to the patients and really kind of get an idea of what's important to them, what I try to do is then help cater a treatment plan. So many of my patients, really what's important to them is maintaining their quality of life for as long as possible, not necessarily being kept alive. However, many physicians think that the goal is to try to keep the patient alive for as long as possible. And I think it's very important that we set and establish what we call our goals of care. Now, many times that involves doing legal paperwork such as an advance directive. I'm a big proponent of anyone over the age of 18 that they have an advance directive. I have an advance directive. My wife has an advance directive. And I try to get my patients to fill one out. One, because it lets us know what you want at the end, especially if you're not able to make decisions. I see people all the time who don't want to fill out an advance directive because they're afraid that we won't treat them, but that's not what that form is for. That form is basically to give us kind of a roadmap, and then at the very end, we know what to do for you. It helps your proxy, who I think everyone should appoint someone to make decisions on their behalf. Oklahoma has specific laws. They're all kind of contradictory. And so I think it's important that you appoint a proxy at that time. The other forms in Oklahoma that you can fill out are what's called a POLST, Physician Orders for Life-Sustaining Therapy. I recommend that's done for any patient who's probably in the last year of life, or a Do Not Resuscitate, which is basically what you would want done if you died. So we address many of those issues with patients. I think it's important that you talk with your family about what you would want done, or talk to your proxy at least. Give them an idea. The other thing is if you can tell them, then at the end of the day, they aren't actually making the decision. They're advocating for you. You've made the decision, and they're just telling the physicians what you want. I'm always happy to help anyone do an advance directive. I do them all the time at the hospital. So if you ever need help with one, stop me when you see me at church. I'll be happy to talk to you about one. One of the things that has kind of brought palliative care up recently has been coronavirus. COVID-19 has been a horrible disease. We hear all the time about people dying. The numbers are going up every day. And while I have not personally spent any time with a patient who had COVID-19 due to some of the rules at the hospital requiring our protective equipment and trying to limit the numbers in the room, I do talk to the doctors who are taking care of those patients. And it's a very frightening time for everyone. Limited visitors can come up and be with them. Many times they don't understand as far as what's going on with them. They don't understand that committing to being intubated and putting on a ventilator could be the end for them. And is that how they really want to spend their time? Just being on the ventilator for a few days could lead to weeks of recovery. and you may never recover. That could possibly mean you would end up into a skilled nursing facility or possibly even a nursing home at the end. Part of my goal when I'm talking with the doctor, especially if we have a chance to talk to the patient, is to find out what it is they understand what's going on, and how would they want to spend their time if we're able to maintain their quality of life and we think it's going to be a temporary thing. Would they want us to do this? Would they want feeding tubes? I also spend a lot of time talking to the doctors about symptom control, and I do a lot of coaching. But I can say that the one thing that I hear a lot from the doctors are the patients are afraid, and they ask many times, am I going to die? And many times we don't know who's going to die. Some patients come in and do fine, and some do very poorly, very quickly. And so it's important that you have spoken to your loved one or your proxies and said, hey, this is what I would want in these circumstances. I want my doctors to offer me treatments that are going to maintain my quality of life for as long as possible. Some are like, I want to be alive. I don't care what kind of life I'm living. And that's okay. Our jobs are to try to help you reach your goals. And even if that goal is to be on machines, then that's okay. One of the other things that we've kind of ran across this is the physicians and the coworkers I work with, their own mortality. And they're very scared about being involved with COVID-19 patients. But I'm very proud to work with these people because they come to work every day and they take care of them. And so one thing that my team also does is actually helps counsel the physicians and the providers who go in and try to help them debrief after they have difficult conversations and talk about what went on. I think at the end of the day, as we go through this world and as we get closer and closer every day to our eventual deaths, we really need to think about what's important to you and how you would want to spend the rest of those days. If you came to the hospital with coronavirus and it was looking poorly, do you want to be stuck in the hospital with maybe only one visitor to come see you? Or do you want to be at home on hospice with your loved ones around you? These are difficult choices, and it's been really brutal to see what's been going on with families and patients at this time. And I really think that the best thing that we could do at Faith is sit and have these more difficult conversations. I'm always open to talk to anyone about their goals of care and their understanding. And please don't hesitate to reach out to me if you see me walking around the church once we're all back together again. I would like to thank everyone for letting me have this time. Thank you.